Good afternoon, everybody, and welcome to today's webinar, where we're looking to explore the connections between community treatment and care service and general practice nursing. And it is our sole focus this afternoon, really acknowledging that we're not really able to address any wider issues, particularly around policy and finance, for example. Thank you. So just a little bit of housekeeping, just as everybody is joining, you will note that both cameras and the mics are switched off. However, there are two options for you with regard to communicating with the team and with each other. So the chat box, which most of you will be very familiar with, which is really for discussion only. And those who may be a little bit less familiar, there is a Q&A function, which you will find just at the top of your Teams ribbon. And that is very much for specific questions for the speakers and for our panel members to go to. And we do have support in the background who will be looking at those questions so that we can address them throughout the webinar. And those that we can't get to, there will be a Q&A feedback form coming out to all attendees. You'll also note, of course, that the meeting is being recorded. Thank you. So I am Joanne Anderson. I'm the National Clinical Lead for Primary Care Nursing with Healthcare Improvement Scotland. And I am inviting you this afternoon just to share with us a little bit of overview around CTAC service, around the CTAC modellings, some of the common themes and challenges that we're aware of, what our demo sites are working on at the moment, and I know that will be of interest to many, and the impact of CTAC on general practice nursing, and a little bit then around career pathways. Thank you. And I'm joined today by our guest speakers and subject experts, Cathy Kenmure, who's a professional nurse advisor for primary care in the Primary Care Directorate with Scottish Government. We also have Andrea Davidson, who's lead general practice nurse in NHS Forth Valley, and also general practice nurse within Antonine Medical Practice. Also Samantha Ware, who's clinical team leader for CTAC services within South Health and Social Care Partnership in Ayrshire and Arran. And last but not least, we have Ruth Cameron, who's a trainee practice nurse within Marnock Medical Practice in Kilmarnock, again within Ayrshire and Arran. And what we hope from you today is that we'd like you to walk away or to sign off being curious about what you've heard and to consider how you take your thoughts forward. And of course, how you begin to or continue to network across CTAC and general practice nursing. Thank you. So where did CTAC actually come from and what's it all about? And you can see that key document there, 2018 GMS contract, which seems a lifetime ago when we think that we've since then fitted in a pandemic and also continued to develop the multidisciplinary team supporting general practice. So it is really around CTAC in particular, we are looking at nursing today, and the whole purpose around CTAC service was not only to support the wider general practice, but primarily around supporting general practice nurses as expert nursing generalists. So we often talk about the medical expert generalists, but this today is really looking at general practice nursing as those expert nursing generalists. We are also going to spend just a little bit of time perhaps thinking about the impact of that, and also what the workforce looks like in the future. And that is just some opinions and thoughts for us to consider from our panel members. And I will touch a little bit on the models for CTAC nationally and also across our demonstrator sites as well. Thank you. So these next couple of slides really is just to look at what CTAC is all about. And this is a direct lift from the GMS contract, where you can see those minor injuries and dressings, phlebotomy in particular. And interesting, it talks about ear syringing, which we probably haven't used a syringe in an ear for about 30 years, and more towards irrigation and microsuction and suture removal, of course. Long-term condition monitoring is absolutely there from a CTAC point of view, and screening tests which really go back to the referrer and don't sit within the responsibility of CTAC services itself, and also monitoring of lab results, which really are then passed on to our general practice nurses, our ANPs, and our pharmacists, for example. And of course, there will be requests coming through within secondary care. Vaccinations may or may not be, totally. Sorry, I'm a bit distracted because I'm aware that there's a little bit of issue viewing the slides, but we'll continue and hopefully people will be able to catch up with that. From a vaccination point of view, there's been various approaches taken, whether that's embedded within CTAC services or sitting alone as a more rounded and complete service, delivering anything from childhood vaccines or non-routines, and of course, travel advice and travel vaccines along the way. Thank you. So when we begin to think about our CTAC models, I think essentially one of the first things is to remember that patients really are at the centre of all of what we're doing around the modelling. And one size doesn't fit all. And of course, there are pros and cons with all of it, with regard to things like communication, continuity of care, inequalities, record keeping, and that IT infrastructure, which we know is a major challenge to us nationally. So we do have, centralised hubs, and some of that is around some existing treatment room services which have been built upon. Our peripatetic teams maybe working, where the demand is across multiple practices, and some home care perhaps in there, and some of those augmented community teams where CTAC staff are embedded within wider community teams themselves. Mobile units, I've not seen terribly many of those, although it may be something that will come and join us at one point. And I know certainly down south they have done some work around mobile units. And of course, we have co-location within GP practices. And of course, important to note that, sometimes you get a little bit of a combination of models going on, and that really is down to choice and crucial to ensure that those CTAC services are accessible, appropriate and effective for the local population. Thank you very much. So common challenges, there'll be no surprises for you in here. It is something that the demo sites are absolutely reporting on, and things that we did know about along the way, and things that we've experienced of late. So we know that premises is an ongoing challenge, and that does reflect in some of the choices of modelling. Recruitment, probably more across the kind of wider MDT perhaps, with CTAC maybe being a little bit more favourable when it comes to a lot of new graduates coming within primary care. Also, the impact of training and the processes around that, and the sustainability perhaps of some of the reliance on our general practice colleagues supporting that, as well as wider community teams. And there has been some alternative approaches around educators in one of the boards. Data, my goodness, it's data galore coming out of our demonstrator sites, but equally acknowledging the challenges around obtaining robust data and what that might look for to us as we move into the future. And missingness, and that goes alongside some of the data and inability to really identify things which are being missed, and the inequalities that actually poses with it. And paediatrics comes up time and time again, where we have adult nurses working within CTAC services, whilst we acknowledge that, cradle to grave within general practice, and our general practice nurses have always cared for that wide age group. And finally, you know, the admin burden. We can't ignore the admin burden that exists and will continue to exist despite some of the best efforts and thoughts how we might be able to improve that moving forward. But, you know, if you double your clinicians in practice, you know, the admin burden is significant. But despite all those challenges, there really are really great examples of really good working models that we're aware of and that a lot of you will be working in currently. Thank you. So just wanted to touch on the work that the demonstrator sites are doing, and some people would have heard about this in the national event just recently, and they all are unique, and it is important to recognise that all of the sites are at various stages of development and implementation of the GMS contract, particularly around CTAC activity. And although I'm kind of touching on the demonstrator site bids, we do acknowledge that they're working on multiple and several aspects of CTAC and pharmacotherapy, and not just the ones that I've mentioned here today. And most importantly, they are taking a quality improvement approach. So NHS Shetland, they didn't have kind of pre-existing CTAC services, and they are looking at long-term conditions, particularly using that house of care approach and how that works across the multidisciplinary team with our general practice nurses and pharmacotherapy working really closely together there. And it will be good to see the data coming out from that. Edinburgh City, we talk about enhanced CTAC service there, and there is a kind of focus around 9 practices there where there's been a huge surge in the population and really introducing kind of core CTAC activities, although there are some exclusions around there, for example, long-term condition monitoring and phlebotomy, which are picked up in other areas of primary care. And really to consider the benefits of particular team members and the impact that has, and looking at ANPs, for example. And unique to Edinburgh City is really looking at the refocused role of general practice nursing, and there is a lot of work going on in relation to that at the moment, and certainly what we're going to speak about today will give you a bit more insight to some of the things around general practice nursing. Borders, they had an existing treatment room service, and they're really beginning to focus on building that service and introducing additional aspects in line with the contract, particularly around that huge ask around phlebotomy, and they will be taking a kind of phased approach to introducing other aspects of the contract. And they have spent considerable time around paying of staff just as they establish that themselves. Ayrshire and Arran is probably a fairly mature CTAC service and have a practice-based model, and they're beginning to look at, and certainly currently looking at, the development of resilience modelling, recognising it needing to be a more sustainable service as we move into the future, and what the skill mix begins to look like within that. And really importantly, the role of the practice educator as we bring staff on board and continue to evolve our services. Thank you very much. So we know that nurses have been in practice for, over 30 years and have seen various iterations of the contracts within primary care. And these are just to highlight the 2 key documents which really run in parallel with the GMS contract. So Transforming Roles Paper 6, and the first iteration of this was back in 2018, and really based on, I suppose, the basics of the contract when we began to think about nursing in general. But acknowledging that we know an awful lot more now about the role of the general practice nurse than we did then. And there was a relaunch of TAR 6 just in February of this year, and that really is reflecting the impact of CTAC and the role of the expert nursing generalist. And alongside that, there was the commissioned work with the GPN Leeds Group, Scottish Government and NHS Education for Scotland, who have produced the Knowledge and Skills Framework, which sits alongside the Transforming Roles paper. And I'll not delve in too much into that because we do have Cathy Kenmure who's speaking next, and Cathy will talk about that in much more depth than I. Thank you. So when we think of the impact of general practice nursing, and this is just really to give just a little bit of insight of some of the things that have changed from a general practice nurse, but acknowledging that it does not reflect the whole role and range of general practice nursing. So you can see the employment status hasn't changed. And, you know, initially in 2017, there were treatment room services. Our nurses, our general practice nurses, were doing both monitoring and management, vaccinations and minor injuries and dressing. So a whole range of activity there. And you can see the shift in 2018, and it continues to evolve, where we see minor illness management coming in, much more around the complexity of care and future care planning, around that real focus on long-term condition management and supporting self-management, and monitoring lab results coming through as well. So just a little touch of some of the early changes coming through. Thank you. So I put this in really just for us to think about career pathways within primary care, and to consider the impact that having the introduction of CTAC services and really highlighting the interchangeability of some of the things that's happening. And apologies to any of our community nurses on the call today, because there should also be a column to the other side there where we look at that structure of our community nursing pathways as well. But our focus today is really around general practice nursing and CTAC. So we know that we have our healthcare support workers, and that is not our focus for today, but didn't want to dismiss that, acknowledging the huge volume of activity and expertise that they provide, and around all the education components that they have, working in the frameworks of level 2 to level 4 and their SVQs. And often we see our healthcare support workers coming into our service further in the career pathway via open university routes or going straight to university from the beginning. So you can see across on level 5 there that we have our registered nurses coming in the GPN pathway side, and also trainee general practice nurses, which we're seeing more and more of just as the people retire who've been established in general practice for a long time, and we are supported with NEST pathway for our new practice nurses coming in. We have our registered nurses coming into CTAC at level 5 as well, and a lot of them come as new graduates, but not solely that. They will come to us from other services, and primary care is high on the list of preferred options as people are qualifying and really keen to come and work within primary care. And I've also put 2P to the side there, just to acknowledge that we have 2Paid staff across, perhaps from some treatment rooms or practice nurses who more of their activity and learning is sitting within CTAC services and don't wish to go on to develop their career much more than that at the moment. Level 6, and you'll see this as Cathy talks about the knowledge and skills framework and some of the TR6 work, where we have those very senior and specialised enhanced practitioners in general practice nursing. And when we look to CTAC, that's where we see our CTAC charged nurses coming in, and our primary care educators. So you can see that career progression is there, and they can move across from one to other. And there at level 7 in the general practice nurse side, we have our advanced general practice nurses, and also those senior general practice nurses as leaders around service development, research and development, and facilitation of learning, as well as team management. And in the CTAC pathway at level 7, we have our CTAC team leaders sitting there as well. So there is that career progression across, and most people will remain within primary and community care throughout their career pathway. Thank you. So I'm delighted now just to introduce formally Cathy Kenmure, who's going to share with us and explore the Transforming Roles framework. Thanks very much, Cathy.
Thanks, Joanne. And next slide, please. Thanks. So I think this is probably more of a discussion piece as to where we've got to and what opportunities provide us in the near future. Thank you. So the background and context on this next slide, when I came into Scottish Government 4 and a bit years ago now, I brought with me a deep understanding of how GPNs were feeling following the implementation of the 2018 contract. And it was clear that there was work that was needed to give balance, a value and a vision for the GPN role, which had significantly changed, as Joanne has outlined. So we needed to get a visibility and a framework around what colleagues in general practice were saying to enable us to create a policy paper. And the evidence we gained from forums, engagement, individuals to groups of GPNs, GPN leads and primary care practitioners and many more. And from that, there were multiple bits of feedback. So from employers and practice managers who are sometimes at a loss to understand what the GPN role is or needs to be since all of those changes. Some of the GPNs were feeling quite empowered and liberated to be able to focus on a role which wasn't dictated heavily by QOF. But then into the mix, we obviously had new additions of staff. So that was a whole system change to general practice, such as physios, pharmacists, community links workers. And some of those roles had taken the work previously connected to a GPN away to other areas, which left a few negative conversations about what was left for the GPN to do. And also GPNs told us that they felt that patient care was fractured and siloed. The other points that they made was that advanced practice for a primary care advanced nurse practitioner overshadowed the role of GPN. They seemed to have a higher value and often directly supported GPs in the growing urgent care demand. And some had said to us, this wasn't our choice, this isn't what we asked for. So feeling undervalued and the job had changed significantly. It's not something I want to do anymore. But I have to note that GPNs said that they had consistently seen patients face to face and often more than others in general practice, and they were very proud of that. Busy general practices, we know that that's the case at the moment, but nursing told us that they feel overwhelmed with work and often focused on acute presentations. They noted that they weren't seeing the people that they needed to see. And I feel that I've lost control of my workload, being pushed into a role that they don't feel competent to do, along with a lack of direction. So now that we knew all of this, what were we going to do about it? So the policy paper enabled us to make a conscious decision to refresh Transforming Roles 2018 to provide a bit more of that balance and vision that practitioners were asking for. Next slide, please. So firstly, that action plan was signed off by Primary Care General Practice Policy Deputy Director and Primary Care Director. That's a really important step because that meant co-production, doing with and not to, an allocation of resource from Scottish Government and security and educational funding commitments, and also that commitment to ensuring that the workforce that is instrumental to primary care is secured. We did roadshows and then developed even deeper understanding of the current state and how that first paper had landed. And if we look at the next slide, you can see that general practice nurses told us about transforming roles, and actually you can see that it wasn't particularly well known, and that was 4 years on. Next slide. So I'll take you on a very quick journey which culminated in the Cabinet Secretary launching TR6 in 2025 in February. And having the Cabinet Secretary shows some real credibility that he has ministerial buy-in and his own buy-in that general practice nursing is now on his radar and really fits in and amongst a lot of the other work streams that we've got going on in Scottish Government. And in the next slide, you'll be able to see that general practice nurses were clear about what they wanted and gave clear instruction as to what they wanted to give them added value. So you can see that from that list, there were some key areas that we needed to get right. And we needed to get right some really valuable points, and such as long-term condition management, the career development that Joanne has talked about, involving employers in development of the paper was a core theme. And in this next slide, there's it shows the journey that we used because there was a very open secret. We were really keen that it wasn't going to be a surprise, and we took people on the journey. We wanted to listen and continue to build alongside you, your employers, and we worked heavily with those people and our board professional leads. But we used 3 questions to help give governance, reporting mechanisms, and structural output to our work. And it was extremely important to understand what we needed GPNs to do. So the questions were, why do we need GPNs? And that's quite clear. But then that question in around, what do we need GPNs to do now that the landscape's changed? And it had changed even considerably since 2018. But the important part was that we were clear that nursing would outline how they would deliver the care based on what GPNs were needed to do. And I think that was the pivotal point in terms of getting your value in across this paper. Next slide, please. So from this position, we built the refresh role over 3 levels. We did have the opportunity to do it from levels 2 to level 8, but in terms of getting us into a concrete stage where we wanted to add that value, it was really clear that that was our first priority. So we got agreement and clarity to what the role of the GPN needed to be, and there were 3 main components, and you'll have seen that through your own work. So we needed to move into a proactive preventative care space. We also recognise that GPNs have got a really strong role in women's health and general practice, and long-term condition management was absolutely core and central. That said, it was really important to those that are working as advanced practitioners who by trade had were GPNs and added that additionality of advancement to the role to include them at level 7. So they felt valued that the breadth of generalism, which was included in long-term condition management and women's health, was a speciality, also really important to be valued. And in the next slide, that was a launch, but we didn't publish it, as in we didn't print it, because we know that when we print things, they immediately come out of date. The structure that we took was one in around competencies, associated education, and it had to all to be free to GPNs at the point of need. And during the process, we made sure that it was available and critical to their success. And I think when we say it's free at the point of need in terms of associated education, general practice nursing is really fortunate, because out with the NHS bodies that our CTAC colleagues work in, unless we provide the education, there is no guaranteed education source fund. So we have retained that educational pot of finance and continue to invest in GPN education. So in the next slide, you'll see this is where we ended up. So we ended up publishing 4 key documents, 2 published on the Scottish Government website and 2 published on NES TURAS website. I mean, knew that it was sometimes difficult to understand what a GPN really does. So to make it easier and to visualise and understand at levels of roles and responsibility described in the framework, NES created a series of short informative videos featuring GPNs, and these videos showcase each level of the framework, offering real-life examples of the GPN role and responsibilities, skills and key education that they've undertaken to get there. And also in association with that, we produced a paper for practice managers and for GPs to enable them to understand what Transforming Rules 6 meant. Next slide, please. So now we've got a clear foundation and some building blocks for level 5 to level 7, with that educational support provided through the GPN pathway at level 5, which involves a year-long study of core GPN learning, and that pivots you into a level 6 practitioner where you're ready to consolidate learning and start to develop at level 6. The GPN pathway is free to all general practices in Scotland. And we've sustained educational funding, as I said, which allows that development at level 6 and advanced at level 7. We've also got CPD Connect, which supports ongoing education with bite-sized learning, PBSGL, creation of new modules such as menopause and CVD to support growth and development of GPN within the transforming landscape of general practice. And we have already got sign-off at level 5 as completion of the GPN pathway, and also sign-off structures at level 7. So we're going to continue to look at what does the next steps mean in terms of level 6 sign-off, which is another goal that we're going to start to progress with. And in the next slide, you can see the implementation, the next steps. We're at that pivotal part of a journey. So NES are helping lead us through this space. We're going to build on the learning needs analysis, which took place just before the March, the end of March. We're creating an implementation group. We'll work with key stakeholders such as practice managers, GPs, and GPN professional leaderships. And we need to embed and support that quality professional leadership through general practice. So you can see from all of that in the next slide, we've got reflections so far. So nursing are telling us, despite GPN's frustrations, GPNs are still focused on people and outcomes. So despite their negative comments in the initial stages, they still want to do a really good job in service for people. And often that's why general practice nurses stay in their role. They want to make it seamless and personal. They want to make that care really pivotal around the person. And they also want to feel valued for the significant work that they do. So in the next slide, there is a couple of slides left. So this is our second last one. And what's in our gift to do different? Now, as a CTAC healthcare professional, you'll have professional structures that offer you that opportunity to have voice, to deliver that knowledge and function and structure up the chain in terms of not just management, but also through leadership. In general practice nursing, that often just stays within general practice. So, but as nurses, we've got 4 pillars. We often concentrate on the clinical pillar, but actually what happens to the other 3 pillars is really important, particularly when that one of those pillars is leadership. And you've got leadership within your gift, but you've also got leadership to work in and across a leadership function that your CTAC colleagues have too. So how are you going to use that position to influence seamless person-focused care? What are the opportunities that you've got to refocus that work within your practice population and within the CTAC population to adapt services which meets the needs of patients and people that you're trying to make their lives better? And not necessarily doing more, but doing different. And then finally, in the last slide, there's some questions here that maybe will prompt us a takeaway and prompt some thinking. So if we're really putting the person at the centre, what does that mean in service reality? Because we've been very good at creating services that fit service needs, but how do we create services that fit the needs of people? And what's that circle of influence that you have? And what can you do? And better, how can you do it? So I'm going to open it back up to Jan. Thank you.
Thanks very much, Kathy. So what we'd like to do now is just to move on to what we've called a sofa session, where we have our panel members, where we have some questions for the panel, just to help us consider some of the thinking of those within current services, and also there's questions that have come in advance, which we will pose to that panel as well. So Andrea, if I could simply ask you first, as an expert general practice nurse, how has CTAC impacted on your practice? And how you consult to support individuals living with long-term conditions now?
So, yep, it would be fair to say that CTAC saw a huge change in our role, actually. And I think initially it was very much seen, it was, as Kathy was saying, it was almost done to. It was a service that was implemented that a lot of GPNs didn't know about. So it was seen as almost erosion of our role. But I think now that, you know, the service is embedded and integrated. And I think now looking at it, you know, it's a real opportunity for us to work differently, to really focus on, I think a lot of us, you know, historically we're doing that level 5, lots of that monitoring, but not really managing. And it's a real opportunity now to really develop competencies, you know, start looking at that journey from that level 5 really through to that senior specialist level 6 and then advanced practice, and really mirroring what, you know, advanced nurse practitioners have and with that knowledge and skills framework. So, and I think, you know, we have to be real about healthcare moving forward, we have to look at sustainability. You know, we're seeing an increase in our older population, multiple comorbidities, you know, increasing complexity. And, you know, our focus needs to really be on proactive risk stratification, you know, promoting health and really empowering self-management through person-led conversations. And I think that CTAC can absolutely support us to do that.
Yeah. Certainly lots of change happening for general practice nurses, and as you say, that perhaps a little bit unclear initially, but perhaps becoming clearer now, the direction of travel. So if you were then looking to the future of general practice nurse as that expert nursing generalist, Andrea, how do you foresee what teams might look like, or what roles they may actually play?
And I think, you know, nursing teams within primary care are not new, you know, I think it's about us working differently, working a bit smarter, better integration with our community nursing colleagues, our community nurse specialists, if boards have them, and our other allied health professionals. And just ensuring, you know, that the right care is delivered in the right place, but by the most appropriate person within that community nursing team. I think with regards GPNs, we've got this real opportunity through the refresh TR6 and the knowledge and skills framework to really look at that development of that role. We've got funding, you know, for that level 5 entry level. We've got funding for that 14-month course through NES that then catapults them into that level 6. We've got funding for everything that supports that, and then very much moving into that level 7 advanced practice. So I would hope to see the framework sort of supporting general practice nurse teams, looking at what their population requirements are and how you know, GPs and practice managers did and senior GPNs develop their nursing teams within practice. So I think with regards CTAC, possibly opportunity for maybe some of the diagnostics that are traditionally done in acute care settings, maybe moving into community settings or hub settings, and very much I would see that personally that's maybe an area that the CTAC service could evolve into in future.
Yeah. So lots of potential change for us in the future, and certainly my own view is that general practice nurses are key as we move forward, as well as the other nursing disciplines. I'm keen to hear from yourself, Sam, now as a clinical team leader within CTAC. Perhaps if you're able to share with us a little bit about your own CTAC modelling in your area, and perhaps some of the challenges working across multiple practice teams, and what you might do or what you've been doing to overcome that.
Yes, I suppose we could start with saying obviously the model that we chose is a practice-based model. That's obviously not something that we just decided to pick at random. We obviously had considerable consultation early on with our general practice colleagues, our GPs, our practice managers and our general practice nurses. And I think the outcome of those that and along with, we did have accommodation in certain areas that were going to prove difficult as well. So kind of the outcome for that, I suppose, was that we agreed that probably to meet the needs of our patient, that would be far better in that general practice setting. And it would allow us to work alongside our general practice colleagues and other MDT colleagues wherever possible. Probably initially our challenges were, I suppose, governance and probably sustainability. I suppose governance in that obviously we are employed by Health Board and we're moving into practice, which obviously they have their own governance within the practice. And to overcome that, probably initially we looked at our service specification, obviously, so that we could set that out in our guidelines alongside the Ayrshire policy. And that to a degree obviously has been very helpful for us in setting up within general practice. Probably the sustainability part has been hard for us. Initially, obviously, well, we've said this, we only started, I suppose, a small test of change, and we had 9 staff. And those 9 staff were actually supported and very much appreciated by our GPNs in practice. You know, we already had a highly skilled workforce that had all the necessary skills in order to mentor and support the staff. But logically, looking at it going forward, we kind of moved very quickly from a small number of staff to within the 3 partnerships. We're probably almost at 150 staff now. So logically, that just wasn't sustainable for us. It wasn't sustainable for the GPNs to continue to support that. Their time's also valuable. And it just wasn't sustainable for us. So going forward, we've looked at the adoption of a new role for us, which would be the Band 6 practice educator role. And this has probably been a godsend for us. It's allowed us to not have that whole reliance on the GPNs. And whilst they're still in practice and still supporting our staff, it has taken away a lot of that reliance and valuable time that they require to do their own job. I suppose the practice educators have been really beneficial. They've made us much more visible in the practice. They've helped us with communication within the practice setting, with the GPNs, practice managers and so forth. And I think it's been really good for us. It's helped us to sort of look at, develop, tailor individual plans to support staff through their training and development. And that's obviously been beneficial for staff within practice. So it has, I suppose, freed up a lot of the time for the practice nurses, reducing that burden upon them.
Yeah. And it'll be good to see, I know that that's part of the demonstrator work, and it'll be good to see evaluation around that role, Sam. Similarly, can I ask you, Andrea had a view on this, and keen to hear your own thoughts about where you see general practice nursing and CTAC teams in relation to other primary care nursing services in the future.
Probably Andrea touched on some of this already. And I suppose logically we're looking at it from the point of view that when we first started, really we identified that half of what the CTAC role was actually initially carried out by the GPNs within practice. So that's been kind of quite interesting for us. And obviously now we're actually transferred over 85% of that transfer. I think it's going to be really interesting to hear from us how their general practice nurse colleagues, what has this time meant for them? How has their role changed as a result? And I think Elaine, Andrea has actually touched on some of that already, and I think it will be interesting to hear from that. But I think kind of moving forward, ours is probably more of the same. But again, we're looking to enhance relationships and continue on with that relationship with some of our primary care colleagues, probably in specific our DN, our district nursing colleagues. And I think it's that kind of collaborative approach that ultimately we are actually all caring for the same patients, to be perfectly honest, and we're just caring at them through life's continuum. So I think it's really important for us to have that collaborative approach to ensure that they are getting the right care at the right time in the right place.
Yeah. Really important to recognise that kind of wider integration and what that means to our patients and those that we care for along the way. And as you say, they will access different elements of our service depending on what is happening in theirs and their families' lives. Thanks very much, Sam. I'm really keen to hear from Ruth now, because Ruth has experience both from a CTAC perspective and now also as a trainee general practice nurse. So Ruth, can I ask you about your feelings and experience and thoughts to date about your previous role in CTAC, and if that's equipped you in any way to transfer across into beginning your career in general practice nursing?
Yeah, absolutely, Joanne. So just when we're looking at that career pathway, I'm an absolute example of me following that pathway without even realising that's what's happened with my career so far. I joined CTAC as a newly qualified nurse, and that then allowed me to experience what it was like working in general practice and understand the ways of working, and also to realise that my passion really was in primary care. I felt like as a student I was always encouraged to work in secondary care, that I'd be working in the hospitals, but I always knew throughout my training that ultimately what I wanted to do was to become an AMP within general practice. And how I was going to get there, I wasn't sure. But then now that I'm actually in this role now as a trainee GPN, it seems like I can absolutely see that goal and can see it in sight and how I'm going to get there. CTAC, yeah, it provided absolutely fantastic support, especially as a newly qualified nurse, and loads of training, which then I think gave me the confidence to say, actually, yes, I can apply to become a GPN, and gave me loads of examples to talk about in the interview when I applied. Fortunately, within the practice that I was working in CTAC, I had a practice nurse that was retiring, and they approached me to say that this position is coming up and would I like to apply for it. And I think as well, I had some questions for the practice to say how would I be as experienced as that nurse that was due to retire, and they could say, well, we'll get you on the GPN pathway. And that will provide you with all your training, and that will give you all the knowledge and all the skills to make sure you can work as a competent GPN. So I'm halfway through the course now. It's actually great, a steep learning curve, but absolutely fantastic. And to know that, I could get on that course, I wasn't going to have to fight for funding to get on the course, and also to know now that my plan is when I finish that in a few months' time, I can really just put all those skills into play, consolidate all that learning, work towards my level 6, and then know in time I'll get to my level 7 with the right support around me.
Yeah, that sounds good, and I'm sure you will get there, and there's plenty of support. Can I ask you maybe just to touch on your thoughts with CTAC and how that supports the general practice nurses, expert nursing generalist? What difference does that make to you?
Yeah, so it's the only ways of working I've ever known is working within general practice as a nurse is with CTAC. So we've got, maybe 4 or 5 CTAC staff that work within this practice. And the GPNs and CTAC team, we work really well together. And ultimately, it's just ensuring that our patients get the best care. I feel as if that we're really on top of all our chronic disease management as a result, because CTAC are there to support us to do all those checks. Then we can then take that, analyze it, and then come up with a plan on how to manage, make the kind of more advanced decisions and how those health conditions are going to be dealt with. It's also having the CTAC team allows us to focus on other areas though, and the parts that I'm particularly enjoying, around kind of women's health, sexual health, with cervical screening as well. And another part that I've been involved in is some QI projects as well. So that's something we're getting to look at to say, right, well, this could work better within our practice, and we can do that as practice nurses to make these changes happen. CTAC as well, though, they're absolutely valuable. Their knowledge is something that we take advantage of. So I always feel as if, particularly the CTAC nurses, are really up to date with all their wound management. And sometimes, as a general practice nurse, you need to know so much. It's such a vast role that you can't keep up to date with everything. And it's good to go to them sometimes and ask for their help. In terms of what's the best dressing right now, and how would you deal with this situation. So we work together both as professionals, and I can't imagine doing it without them.
That's good to hear, and really valuable to hear your thoughts, Ruth, when you have experienced both elements working within primary care, and certainly would wish you all the very best in your venture towards advanced practice as well.
Thank
you. We have some questions coming in, and I'll maybe ask Sam if I could. One of the first questions that we have here, which is around patient experience. Sam, is there any survey information, was the question, or anything happening around gaining our patients' experience of CTAC services?
I think yes, absolutely. As you know, obviously we are part of the demonstrator sites, and within that, at the moment, we have already collected some early information from patient experiences. It's been actually really, really interesting, the CEIM conversations to date. Obviously, we're still working on that and collecting further data, but to date, I would say that actually it's been very positive for us.
Good. And I know that other demonstrator sites are also working on kind of similar approach, looking at that user experience as a means to improvement as well. So information that we will see coming out in the future. And I know that other boards will have taken similar approaches as well. So yes is the answer. There is work being undertaken around patient experience. There were a couple of questions, Sam, and I might just stay with you if that's okay.
Okay.
Just with regard to the practice educator role, where firstly there was an ask, was this very specific to CTAC, I suppose, or did our educators work across both general practice nursing and CTAC?
Obviously, predominantly we do work across CTAC, but to be perfectly honest, we've had times, and I think it was brought up early on to say by Ruth that obviously there are times when our staff are maybe more up to date with our wound care. So we actually have had experiences where the practice educators have actually supported some of the GPNs in practice with wound care. So I think there is that kind of, I suppose it's that kind of, vice versa, we're happy to support where we can. And again, that's reciprocated with the GPNs. And I think that's all part of that relationship building.
Yeah. Absolutely. And interesting, I had a conversation with a colleague just this morning around similar approaches, very specifically around supporting our general practice nurses in a similar way. So it will be interesting to see where those conversations begin to take us. We have some other questions that's come in the Q&A, and one of them is from David. And David, I'm kind of hoping that as Andrea and the other panel members have been talking, that it does answer your question, which was really about that kind of real jump in expertise that our general practice nurses require to kind of look at that kind of future role and about funding for that. And Andrea has touched on the pathway, and there's also all the TURAS learning and funding for specific modules, for example, prescribing, assessment, decision making, leadership, etc., which has all come from NES, and I'm sure Kathy would support that answer in saying that general practice nursing has been very fortunate that we have ongoing funding from Scottish Government and commissioning to NES to support our general practice nurses moving forward. There's also a question around kind of hub style models, and there is variation, as I say. I know there's certainly hubs within Greater Glasgow and Renfrewshire, and also Lanarkshire. And there's also some hub models in Lothian, and I'm sure there will be others. But in answer to that question, I'm sure we would be able to put you in touch with boards who do have a hub approach, if that would be helpful. Just scanning to see any other questions that's kind of coming in our way. And there was also a question around remote and rural areas and inequalities around some of the modelling, and I hope that I was able to answer some of that earlier, just when we spoke about some of the different models and the responsibilities of our health and social care partnerships to be able to design those models that are fit for purpose for the population. And when we think about some of those augmented community teams, how that general practice nurse role may fit within that in a remote and rural setting, rather than siloed practice. And at the end of the day, we are looking to provide the best possible care for our patients. There are other questions coming in, and our aim is, along with the slides, to answer those questions in a Q&A document, which will come out to everyone in the next couple of weeks. So things that we've not touched on today, we will certainly address in that way for you. I would like to thank our panel members for their thoughts and participation, and I hope that's given you some food for thought to take away with you today. We do have some poll questions, as you would expect, just to gather your thinking on the session today. And then that's followed quite swiftly by a feedback where it gives you a bit more opportunity to tell us a little bit more about what you've been thinking about the sessions today. And there is a couple of questions within the feedback which will come up after the poll, which is very specific to those of you on the call from a CTAC point of view, where we're keen to hear specifically about your thoughts around ongoing networking for the future across the wider boards, not just associated with our demonstrator sites. So we'll give just a few minutes, and we do really appreciate the responses that we have in our polls and our feedback, because it very much informs how we begin to take things forward with our future webinars and communications coming out to yourselves. So I think that pretty much brings us towards the end of our webinar today. And at the beginning, I was hopeful that you would sign off being curious about what you've heard and begin to think how you begin to take some of your thinking forward. As I say, we will send the slide deck out and the Q&A sheet out in the coming weeks. And the webinar is, of course, recorded for you to go back and listen to for areas of interest. And do apologise to those who've had a little bit of technical difficulties in the background with the slides moving on, but hopefully when the slide deck comes out to you, that will fill in the blanks. And I hope you've enjoyed the session. And a final thank you to our team in the background who've kept everything going, very much appreciated. And a huge thanks to Lane, Jess, Marie and Sarah, and of course yourselves for joining us, which makes it all worthwhile. Thank you very much.